they carry some kind of abnormality in them. So next question.
One more about the morphology part is to assess the morphology, you need to have a good time. You cannot give the morphology report within an hour or two. You have to release it in the next, maybe next to next day, because every sperm is to be stained and seen in a proper way. The head, neck, all those things are to be mentioned in your report. If you see the WHO report, then only we can do the morphology. And if we ask from the house, even myself, I don't, keep myself away from all these things. We never assess morphology. Morphology again is what your embryologist or technician or your IVF specialist would see it by the slide only. Will not actually going to say. चल रहा है, it's okay. नहीं चल रहा है, there's some problem. That's the problem with that.
I think in WHO manual 2021 is even in 2010 progress criteria type of criteria. Yeah. They are very strict. That is why the 4% is there. That is why. Yeah, exactly. And in that in OPDs itself we have to do pap stain of all the smears, but we don't do that. That is not being done at all. Yeah. That is I think in institutions. I think grossly it is if all the sperms are abnormal, like you have globospermia or pale head, so then that there is a genetic aspect. If a fixed percentage, so that is like not that all that important, like the implication for a uniformly abnormal sperm. And diabetes is one of the diseases where we can find most of the abnormal sperm. Dr. Chapa, you want to add something?
Sperms are peculiar, they are very abnormal, it is only cell and so much abnormalities. It may be due to compactness of DNA. It is 6 times more compacted. And there is special annular ring structure around the nucleus. Both arms, long and short arms are flexible. In any way, spermatozoa is little word. Sperm word came from Greek word seed, and zoa means leaf.
And sperm is happiest either in the testes or in the egg. In between, from epididymis to the sperms, urethra, and then to the vagina, all there are the things which are going to attack the sperm. So sometimes what happens is because of the delayed laser peristalsis or because of the long time in epididymis, the abnormality is there. Over to Dr. Salit.
So again, back to Dr. Monica. So leukocytospermia. Lot of times, the patient would be running around saying that there are first cells in the semen analysis report. I have taken a lot of antibiotics. They are still there. And you advise, me advise, our colleagues advise semen culture. How relevant is leukocytospermia and those cultures?
So if the WC count is more than 1 million per ml, then we can call this sample is leukocytospermia. And in male urogenital system, many infections are there, whether it is protozoal, bacterial, viral, fungal, and they can lodge in the female genital tract, and then it can cause multiple recurrent implantation failures, and it can cause infertility, and it can cause molecular level defects in the sperm, and that can lead to infertility. So leukocytospermia is very important, and we don't have to give like doxycycline like that antibiotics, empirical antibiotics. We have to go for culture test, and then we have to prescribe antibiotics and treat accordingly.
Dr. Monica Verma, do you agree with this?
When we say leukocytospermia, that means we are talking of more than 1 million peroxidase positive cells. So that means either it's an inflammation or it's a infection. Now that infection could be viral, it could be bacterial. So we have to see the clinical aspect of it, whether the patient has any symptoms related to a lower genital tract infection, which is most of the time not there. So the guidelines say that whenever you have this, even if you get a culture, these the organisms are not going to come in a routine aerobic, anaerobic culture. So the guidelines are very specific in saying that if there are no symptoms even, and if you don't get a culture but you have leukocytospermia, then you have to get doxycycline for 1 month, that is 100 milligram BT for 4 weeks, and frequent ejaculation every 3rd day is what is recommended. And there is no need to repeat and see if the leukocytospermia has subsided or not. So that
you use a word peroxidase positive.
Yes.
So what is that? Round cells?
These are peroxidase cells in the granulocytes. So when we have round cells in the first analysis, the simplest test is to do a peroxidase positive test. That gives the brown color for the polymorphs, but the lymphocytes and macrophages are not detected in it. So basically, it's knowing a polymorphs versus the other round cells.
The message for the house, basically what she is saying is, it is basically what we see is the round cells. They don't necessarily actually are the WBCs. It can be your spermatogonias, your spermatids, all those immature, cells which actually have been wrongly labeled as the WBCs. So if the round cells are more than 2 million count, then only you are supposed to see that it can be WBCs. And if you want to see the WBCs, again you have to stay in this line. So the patient generally would not have any symptoms. So doing and labeling it as a leukocytospermia, I would say, is a wrong again. And the semen culture role again is no proven role. So again, the message to the house would be the semen culture again has no recently proven any evidence to offer to your patients.
Do we routinely do hormonal evaluation in our male patients?
No, we don't do it routinely if the semen analysis is normal. Only in case of oligospermia or oligospermia, we go ahead with the hormonal evaluation.
Dr. Chandra, what is your choice of test for a patient with oligospermia or azoospermia?
All repeated chemotherapy, all repeated, not on single port.
See, thoda,
All repeated semen examination. It is not on single port. If it is oligospermia or azoospermia, then start from history. So many points to get from history.
Yeah.
That's general physical examination and only focused investigation. Not straight up.
And what are those blood tests?
We first,
After the history, you got to know that it is azoospermia, and secondly, sexual factors are met with another.
history.
Yeah.
It is not only for patient, from his parents also.
Okay.
Childhood history. Patient.
Any trauma, any mumps?
Yes.
Yeah.
It is not straightforward
Dr.
investigation.
Surjit, any investigation you would like to do in the patient of oligospermia or azoospermia? Any hormonal evaluation?
We are doing FSH testosterone.
So FSH and testosterone are basic investigations, and sir, what are we going to interpret from them?
In fact, I think we should go for ultrasound rather than like rule out varicocele or any other thing. That ultrasound is also.
We'll come to ultrasound later on, but we are talking about the hormonal evaluations.
CME mentioned for
Yeah.
basic.
So when the abnormal sperm parameters are there, or there is impaired sexual function, or other findings that are suggesting of endocrinopathy, then we are going in for FSH testosterone. Additionally, we can get in LH and prolactin levels. So if we have all, why we are interested, Dr. Monica, why we are interested in these hormonal levels?
See, when we have oligospermia, I think TSH and prolactin is very important. We diagnose a case of macroadenoma with oligospermia. So we shouldn't miss out FSH, testosterone, LH, FSH, and TSH and
So
prolactin.
this is the message for the house.
And then according to the history, whether it's hypogonadism or hypergonadotrophic hypogonadism, then further we proceed with what is to be done. These tests have to be done.
I would like to add and ask we have a lot of males sitting over here, the gynecologists. Now this question would go to the female gynecologists.
Yeah.
Raise your hands who have examined the males in their openings. The male testicular. Any female, if we say you have done. If I being a male can examine a female.
We get it done from our
The basic idea is if I being a male gynecologist can examine a female, the females can examine the male too. Our examination is going to make a huge difference, and believe me, more than 90%, that if you are experienced enough, almost 100% of your cases of obstructive, non-obstructive azoospermia can be tackled by the examining your male genitals. Good thing with the male genitals is the God has given them outside. We don't have to do, ovarian reserve, we have to do ultrasound. We have to go inside and see. But it is hanging outside. They are there to talk to you. So why don't we go to them rather
It's
than...
not very easy for you to say.
No, but,
There are many males who are very reluctant for a physical exam by a female.
But I think it's a very valid point these days. If you see lots of people who are going into the gymming and all taking
Anabolic
testosterone.
steroids, yeah.
And by the time you ask them for ultrasound, they'll hesitate. But there and then the atrophy of the testis is there.
No,
And there and then there is no need
No
to say
message for the ultrasound. No ultrasound.
No, there is no
ultrasound. I'm saying you physical examination.
Yeah.
And you just see that the testicle is so atrophied, and when you ask, they'll be taking
Yeah, those
latest
anabolic
testosterone.
steroids, true. And FSH, LH, testosterone low has got a very good importance because there is a medical treatment available improve the sperm count in these patients? Dr. Monica, can you highlight the importance of low FSH, LH in the patient and low
So these patients would be either a case of primary congenital hypogonadotrophic hypogonadism or one that starts at puberty. So you get an idea from the parents whether the patient needed testosterone or the delayed sexual character. So the management is different. If it's a case of congenital, then the patient is not really going to respond to HCG directly. So you straight away start with HMG and HCG together and give these injections 5,000 divided over 3 days and HMG 150 divided over 3 days a week. And then after a month, 1 or 2 months, titrated by the testosterone levels. But the ones who have had puberty and still have a low FSH, LH with a low sperm count or nil sperm count, and these are the patients who are going to respond well to medical treatment.
Yeah.
So we should try HCG first so that the local testosterone levels increases, and some may respond with even HCG after 3 months, or you can add on later after 3 months, add on 150 HMG or FSH as your
Dr. Chawla, any role of letrozole?
Welcome, everybody.
Yeah. So anybody who is trying letrozole or anastrozole in
Testosterone has negative roles. It is less.
not the testosterone, the letrozole or the anastrozole. In obese patients, in obese male patients,
Hypogonadotrophic.
not in hypogonadism, in any indication of male subfertility.
Hypogonadotrophic hypogonadism.
Yeah.
Testosterone level is testosterone over equation.
Yeah.
Testosterone means nanogram per 100 ml.
Yeah.
It will be 500 per ml. It is less than 10. Then allopathic in system has got very good.
Very good role. So there are now options available for the medical treatment also in male infertility. So whenever we get a patient with polyspermia or azoospermia, we should get an FSH, LH, testosterone, thyroid and protectin levels for this patient. Over to Dr. Sir.
Antioxidants. I'm sorry, we have our sponsor also is carrying an antioxidant. What about the antioxidants? We all everybody gives it.
Yeah, antioxidants definitely they do have a role in male infertility. We know antioxidants are they play a huge role in causing infertility. So vitamin E, vitamin C, selenium, zinc, and CoQ10 and carnitine, all these they have a great role in male infertility.
So you're giving, Dr. Monica.
Yeah, because our lifestyle is like that, now obesity, diabetes, and our eating habits are like this, lot of pesticides, so this has a role.
Dr. Monica, आप दे दी?
With those who are alcoholic and those who are oligospermia, so for those 2 months prior to preparing them for IVF, there's no harm to it. The guidelines don't have the evidence. So till they have the evidence, we are getting it. 2 months.
Who is giving antioxidant in the house?
So antioxidants, people in for antioxidants in male infertility.
How many, can you say how many believe that antioxidants actually increase the sperm count? Actually,
They're not going to increase the count. It could be the quality, we don't know. But because it doesn't have any harm, we are giving it.
It's more of a placebo, I would say. Majority of it.
Sperm DNA integrity, that is what otherwise it decreases sperm DNA.
The thing is that we don't have evidence, but yes, we all are prescribing it. The reason is at least we have some energizers. Maybe it is going to give a positive response to our patients. It is giving or not, we don't know. The actually don't know, the SRM don't know, nobody knows it whether it is giving any benefits to our patients or not, but definitely it is giving benefits to us and our patients in a different way, the commercial way.
Even doctor says after 3 months, patient will complain that pregnancy has not occurred because you have not prescribed
Next question to you. So this is a case study. 30-year-old patient presented with primary infertility of 8 years. Menstrual history 3 by 22 to 24. She had short cycle, cervix healthy, breast examination normal. On TDS, uterus normal size, bilateral ovaries had low enteral follicle count. FSH was 6, LH 1.35, prolactin 11.4, thyroid 1.44, AMH 0.5, and all other tests were normal. Male partner 38 years old with hypothyroidism, no secondary sexual characters are well developed, testes are normal in size, sperm in consistency, bilateral valves not fed, on RLC nil sperms, FSH of the male partner is 4, LH 2.56, testosterone is 278. Scrotal ultrasound shown bilateral extent vas, and ultrasound abdomen showed no renal anomaly. So Dr. Monica, how to proceed?
Fructose, pH, and volume of the semen.
There was volume was almost less and fructose was negative. Yeah.
So,
This is fructose test is actually not done.
okay.
Yeah.
So we are.
Anyhow, those,
Yeah.
because
This is a clear. Yeah.
reading this.
No, it's a clear, but still when we have.
Okay. Okay.
I think we should still do it. It makes it more clearer.
Okay.
So this is a case of obstructive azoospermia with bicongenital bilateral absence of the vas, and they have very good prognosis with testicular aspiration with IVF and HC. So now, can we have?
Do you? Yeah. The female. Yeah.
Now, as she is going to go for IVF, she has a little unusual low AMH at 30 years, 0.5.
Yeah.
So for stimulating her, we need to, I would like to know her E2 levels to see E2 level.
It was 56.
And if there's any family history of a premature menopause or any family history suggestive of a fragile X.
No. No.
So then she is going to have a stimulation protocol for pertaining to her
Do
AMH.
you go in for FNSC before going in for seeing these patients, Dr. Pooja?
Diagnostic FNAC.
Is it required, Dr. Monica?
It is required.
So that we can consider.
And fructose is not required, then it is not required, but I think it's a simple test. You do it, you're at peace. Yes, you have a diagnosis, but it is not required actually.
Okay.
And I like to tell you one case. This patient, he was a case of obstructive azoospermia, married for 15 years. They did an FNAC from somewhere. It was nil sperm. So then for 15 years, she was on donor insemination, not knowing that it was a case of obstructive. Then when they came to us for donor insemination, we investigated. I said, you have to have sperms. There is no question.
Yeah.
So she was ready for a donor insemination. So we did an IVF and there was sperm. So even if you
Any
don't do
special
it-
investigation for the female partner when the male has obstructive bilateral congenital absence of vas? Any special investigation in these cases required? Yeah, so that is one thing which is required for the female partner. Dr. Monica.
This gene mutation is not so simple to say that you're doing a mutation testing. Once the guidelines now 2021 of ASRM say that the male partner has to be tested first. It is 80% that mutations are going to be there, but first it's the male partner. Initially it was the female, but now 2021 it's the male partner. It has to be tested first, and there are around 2,000 mutations. So if we ask for a mutation from a lab, go to Lal Path Lab or Light Cells, they are first doing the main 2-3 mutations. You have to specify how many mutations you want to be checked. There is a panel maybe of 10 common mutations or a panel of 100 common mutations, but still we will not be ever able to be sure that this patient is mutation free or not. So whenever we counseling for these patients, either we get a full gene study to see for the mutation so that we don't miss it, and then for the female also, and even if the mutations are not there, we cannot give it in writing that they are mutation free because there are more than 2,000 mutations. So for this counseling, it has to be mentioned that we are.
Ours is not an endemic area for cystic fibrosis in India.
But still
I
we do
do one of my relatives, I've gone into this, she is in America, my cousin, she had a mutation which was major mutation of Switzerland. So we don't know from where. And India, the demography, they don't have any data of which are the mutation. I just saw there were just a few papers which say that these are the Indian mutations. Indian mutations haven't been studied.
Actually, the CBAVD, they say that it is so severely, almost 66%, two-thirds will have actually CFTR. So we
Yeah.
can skip the
male part and you can go directly to the, but then your point is valid, we will go through it. So the patient was stimulated with HMT, only 5 eggs retrieved, but she was able to make 3 embryos and 2 transfer was done and 1 intrauterine sac was there. So these patients, they do have very good
Kumar, one more point that I just want to make over here is before any message is given to the house, the doctor had advised that it's total USG for VAS. So total USG is not to be advised for the VAS, it is only to be clinically palpated. This is what I wanted to emphasize and I'm saying it repeatedly. Ultrasound can miss the VAS. It is so small that especially in those cases where it is aplasia, it is going to miss that and it is going to make a huge difference to your management. It is only the clinical part. Just scroll your hand down and you'll find one wire kind of a thing. It is a VAS. If it is not there, it is not there. Ultrasound is not to be done for these parts unless you find some other kind of pathology in this. So ultrasound, no, ultrasound, no, ultrasound, no. This is what has to be taken unless you find any masses or something.
I think we are running.
So ultrasound hormone for you.
Yeah, renal analysis has to be done. Yes, that is always there. Yeah. Thank you so much, panelists. We are running short of time, but we are not running short of our questions. Thank you so much. Thank you, Dr. Anupama and Dr. Sarabji. Okay, for this, everyone can come to the dais. Yeah. And now I invite Dr. Anupama and Dr. Sarabji to facilitate the chairpersons and Dr. Jasmine to please join them. Dr. Nandita, please join to facilitate our chairpersons. Dr. Deepak, please join. Dr. Monica, please. Both are Monica's. Yeah, everybody can come. So I invite Dr. Kapshi, our immediate past president, to join. Dr. Pooja.
सर थोड़ा देखो ना आप भी डॉक्टर साहब
Dr. Chawla.
Yes, sir. Doctor sir. Yes. I got
Dr. Amarji. Dr. Suji.
Yes. Wait.
Mr. Rajat.
वेट करना इस साइड देखना सब थैंक यू
Dr. Suji.
यस सर वेट
सर थोड़ा यस
Thank you. This is houseful. Now I invite our chairpersons to honor Dr. Anupama and Dr. Sarabji. Dr. Nandita, please stay.
सर थोड़ा
Yes.
Wait. Decide. Yes, sir.
Now I invite our chairpersons for the next session. Dr. Harinder Kaur, please join. Dr. Sushma Chawla, Dr. Sujeet Kaur, Dr. Amita Sharma, Dr. Harinder Kaur Abroy, Dr. Kamal Gupta, Dr. Kamal, please join for the second session. I invite our chairpersons for the second session, Dr. Harinder Kaur, Dr. Sushma Chawla, Dr. Sujeet Kaur, Dr. Amita Sharma, Dr. Harinder Kaur Abroy, I invite our National President, ISAR, Dr. Nanda Seshwar ma'am, for her talk.
And it will take a year or 2 years for us to give it back to you.
Good evening, dear friends. Good evening, dear friends. It is my proud privilege to introduce Dr. Nandita Pashekar, who actually doesn't need any introduction. She is already known to everybody, whole house, all the gynecologists of this country. Even then, it's a formality and that I do. She is an eminent IVF specialist with more than 50 years experience. She is medical director of Blue IVF, has seven centers all over India. He is MD of Katikani, GMC Hospital, Mumbai. He specialized in art from world famous IVF units in Belgium, Italy, Melbourne, and Copenhagen. He is pioneer in India for latest technologies, ICSI, laser etching, blastocyst culture, spindle fuel, oocyte, embryo and ovarian tissue freezing. IMSI, in vitro vaginal culture, metacolono, embryoscope and spindle technology. PG teacher, fellowship in reproductive medicine of National Board Delhi at Lilavati Hospital, Mumbai. Trained 5,000 gynecologists in fertility all over in last 15 years. She delivered 70 plus orations and more than 900 talks. Authorized more than 100 chapters and faithful and dedicated to things. Her profile is very long and very luminous, but I for coming to Jalandhar and enlightening us. Thank you.
Beautiful person from Mumbai to Jalandhar. अभी वैसे लोग पूछते थे ये होलिस्टिक क्या चीज़ है? मैंने कहा यही तो एक लाइफ है. So we are going to tell about it. I was just sitting and talking to Mandy and I'm meeting everybody after so long. I think I've come to Jalandhar after 5 years. And it's so beautiful coming back and thank you all of you all for being here. I think it feels so good. It really feels fabulous. And I'm happy that I've come for such a great occasion where I'm appreciating all the IVF people of Punjab. I think that has been a dream of mine, and IVF is a passion of mine. And to appreciate people who have been working in IVF for so many years is something really which I wanted to do from the bottom of my heart. And as a president of ISAR, I got this opportunity. So I'm really, really happy to do that. So, but of course, I had to, deliver a small talk. And this talk is actually about aging unraveled. It's the mysteries of aging. I think as we all are aging, I got into this whole, when I became the president of ISAR, I got into this enigma of aging and really got deeply into it. And I realized a lot of things which we are not even aware of. And I think as obstetricians also we need to be aware of. And the role of endocrinologists, reproductive endocrinologists, that is us IVF specialists, actually expanding. And I think it's beautiful today the way we are able to help the women in different fields. So my talk is going to be about all that. Holistic health, but it's mainly focused on aging. What is happening? Hello?
I'm just taking my iPad.
क्या हो रहा है? अच्छा, the Mac. Okay. Can we convert it into PowerPoint? No, it's a beautiful presentation. The beauty of it is in all the fabulous, I want to show you Avatar movie. So the presentation is something like that. So if I convert it into PowerPoint, the whole beauty of it will disappear. So I think that's what they're trying to do. You want to? I have a pen drive. I have a pen drive in my purse. I think a woman's purse has everything. If we had no great treasure, I think we will. I think Jasmine has been working very hard. She's really been working with the team. I haven't been able to help her much. Oh wow. Thank you. तो अभी शिफ्ट कर दो. आ गया this is. Can you connect my ये कौन सा वाला लगा है? This is genomics, yeah. This is my pen drive. ये पेन ड्राइव है. ये पकड़ो. क्या करना है? ये कॉपी. By the time Dr. Nandita is talk, I think since we are all EM specialists, ERT specialists, I think we really need to work on the mind, body and soul, which I think most of the time we forget. We in Jalandhar, we have a very strong women doctor wing. I think they are working with the yoga, and I think most of the people are now into lifestyle modification, dancing. I that should be a part of everybody's life, exercise, yoga, enjoy. Otherwise, everybody is, busy doing, sperm count. So I think this is what she's going to tell us. And please take out some me time, which is very, very important. नहीं तो देखेंगे तो जिंदगी वो गई गायब भी हो जाती है. So don't let the things go like that. आपने कुछ कहा?
Holistic approach of women is very important. As you know, it is not just the physical health, but it is also the mental, emotional, and spiritual health is very important. So as we by this approach, we can reduce our stress, we can reduce our chronic illnesses, we can reduce our psychological problems, especially after menopause. So this thing is very important.
Good evening. Finally, I think we want the aging to be delayed, so the presentation was delayed. So the whole presentation, so aging unraveled is my talk. I want to just tell you, all of us think of aging what? When the woman hits menopause, that's aging. But there is this young Finnish study where they actually studied the DNA. And according to that, actually at the age of 15 years old children showed a kind of a curve, and that curve remained the same even at 40 and 50. So the aging actually is determined when you are very young. And this was a young Finnish study. This is the Dunedin study where they studied adults at 30 years, 40 years, 50 years. And they actually found that there is a pace of aging. And that is what is important, because we as adults can actually control the pace of aging. And they studied various markers, cardiovascular, the brain, the heart, the lungs, the kidney. Of course, they didn't study the ovary, but they studied different markers, and they realized that each individual has a pace of aging. And these are important words that you must remember, that aging starts early and that there is a pace of aging. But remember one thing, there was a study in Harvard which actually studied all the organs except ovaries. So women are often neglected, but now what they've realized, the NIH, the American Society, all of them, their funding is now dependent that you have to take the women. Because 8 out of 10 drugs were actually rejected because they had side effects in women, because the physiology is so different. So the ovary is the first organ. Before any other organ ages, the ovary actually ages. In fact, it's a time machine. It reaches the future before the entire body reaches the future. So the secret of aging is actually hidden in your ovaries. So the question here is it time to cancel menopause? I think let's not be so, full of optimism that we can say that we can cancel menopause. Yes, let's divide it into different ages. If it's a young girl, 28-year-old, we are seeing with low AMH. I think she just demonstrated a case just now. Yes, in her case, we would love to cancel menopause. But if it's a 35, 40-year-old, we'd like to delay it. And if it's a 50-plus woman, what we would like to do is we would like to change the quality of the menopause. I think this is how we are looking at menopause in a woman. In fact, there are a lot of studies which show that there are only 3 species in this world where women, the female species, lives in their menopause. The whales and the humans. Rest of the species all die in their fertility. In fact, that is probably because the longevity has increased. Otherwise, women in the 1800s used to die at the age of 40 and 50. So they were fertile. They didn't have all these problems which we are facing now because of menopause. So all the science is new and we need to understand it. So reproductive longevity is definitely linked with health and life expectancy. The longer the reproductive longevity, longer is life, and longer is the quality of health which is associated with it. The ovary definitely, can I get some hot water? That's all. The ovary definitely shows signs of aging before any other tissue. So if you really want to understand aging, we actually, if you understand aging, we really need to go right into the basics, into the uterus. Actually, aging starts there, and that's what we need to understand. So let us go look right into the womb and see what happens and how we can help. To understand that, we are all reproductive medicine specialists. This science did not exist before the 1500s. 1558. That was the first time when William Harvey, who was the physician to King Charles I, and he's the one who said everything comes from the egg, because before that Aristotle said sperm is the one which gives life. But everything comes from the egg was actually discovered by William Harvey, and then reproductive medicine as a field actually began and people started researching it. And the germline which exists in all of us, which goes from generation to generation, actually comes from the woman. And this germline is immortal. You can actually trace back your ancestors right to the first person. And this germline, now when you pass your germline to your child, you have a child at 20, you have a child at 40. I mean, as you age, your germline also gets affected. It's impeccable. It's not immune from decay, aging, and errors. So there are things that affect it. The aging affects it, the chromosomal errors affect it, the environment, the toxins, the endocrine disruptors which are there, they affect it. So what actually happens? How does the child get fabulous gene? You remember Dolly? Dolly was cloned, but Dolly died at a very young age. Why? Of old age diseases. Because the germline was not rejuvenated. What happens in the humans? In the humans, the cells go to the brink of death. They age and they come back to life, and that is rejuvenation. And how do we know this? These are epigenetic clocks, which research was done by a scientist called Vaden, and he's the one who invented them. And what he has shown is when a blastocyst embeds, implants, and becomes into an embryo, implants into the uterus and grows, at that point there is a ground zero where all the germline resets and becomes young again. But did you know that with the help of these epigenetic clocks, you can actually time the aging. The aging starts 45 days soon after conception. So the aging starts in the womb, not at 40 when we think of menopause. The aging starts in the womb, and the rejuvenation also starts in the womb. But the pace of aging is what we expose to, what is our lifestyle like. So we as obstetricians have to guide our pregnant women. We have to tell them that if you want your child to be healthy, you have to take care during those 9 months, because that also determines the life of the child, the health of the child, and how we all know Barker's hypothesis. This is actually what happens inside, and these new technologies are actually revealing all these secrets to us now. So, aging starts as early as 45 days after conception. There's billions and billions of dollars being spent on research on aging, and these are the 9 hallmarks of aging. I'm not going to cover all of them because it's virtually impossible to do that. But yes, today in my talk, I'm going to briefly touch on this: the DNA damage response, mitochondrial dysfunction, apoptosis or cell death, genomic instability, and telomere shortening. These are all big, big words, but I'm going to really tell you very simply. DNA damage responses is something that our cells are doing all the time. You know, if there is a DNA damage, your cell has the capacity to repair it. So if you look at the ovary, what happens from womb to tomb? There are 5 things that happen, critical factors that impact it from the birth. Inflammation. Inflammation you usually see when the person grows older. Then there's autophagy. Autophagy is a lot when in the womb and in the later phase of life. Then DNA damage response is seen throughout. The ovary has a fabulous DNA damage response. And aneuploidy. Aneuploidy we know occurs in the womb because a lot of eggs are lost, and then as you grow older it happens. And mitochondrial dysfunction, that can be present throughout. So, what are the points of intervention in these 5 critical factors? If you look at it, environment and lifestyle factors are implicated in promoting aneuploidy in the oocytes. So what happens is when there's aneuploidy in the oocytes, it causes aging and depletion of your ovary, and that causes aging of the other organs also. So this DNA damage response is accelerated. Obesogenic diet, exposure to environmental toxins, all these factors affect the woman. This is a beautiful scene from Lord of the Rings. What it says is ovarian aging is a game of death, actually. And what is happening is because of all the toxins that we're exposing our body to, actually our civilization will dwindle and become dust. So we need to really wake up now. Our generation has been a generation of excess because we've realized that they must use this wealth wisely. If you look at the younger generation, my laptop is not working, so the volume is not there. So to understand what is happening, how do we bring back the aging cells? You have to understand what happens, what is death of a cell. So death of a cell is very simple. The mitochondria, which were previously known as energizers, are also responsible for the death of the cell. They have this mitochondrial permeability transition pole, or these are in simple words, they're known as gates of death. When they're exposed to environmental toxins, increased ROS, any kind of poison, they open up. And what do is they release cytochrome C into the cytosol. And this releases the executioner. What is the executioner? The caspase proteases. These proteases then start destroying the cell. They destroy the DNA, the cytoskeleton, the entire cell, and then autolysis takes place. So if you really want to stop the cell death, you have to stop this protease, this caspase, and then you can bring back the cell from there. So you need to know that. Chromosomes are very, very important part. All the time in your body, the genomic instability is a hallmark of aging. The better are your chromosomes, the younger you are. We always say it's in the genes. Parents are genetically young, you are genetically young, but you can abuse them. And you need to understand what are chromosomes. You can see on the left side, chromosome DNA is on the string, the beads are DNA. Sorry, this is due to non-stop talking. So the chromosomes are actually all bundled together in the nucleus. Can you imagine this is 2 meters long in the nucleus? You can't even see it with naked eye. You can imagine how beautiful and how fantastic it is that for 2 meters to be crushed into that nucleus. And this is the dance of the meiotic chromosomes. When meiosis occurs, the oocyte becomes M2. The spindle is formed and the chromosomes divide. It actually, there is beautiful, the technology today shows how they split up, and it's called the dance of the meiotic chromosome. And it has to occur normally. When it occurs abnormally, you get aneuploidy. And what happens is, let me tell you, show you the next film. Is it, what is happening? Yeah. So this is the most beautiful secret of the DNA unraveled. You can see that blue molecule. Okay, this is how flesh and blood is converted into, a DNA code is converted into flesh and blood. So this blue molecule actually is passing, there are promoter molecules which come at the beginning of a gene. Gene is what? Just an set of instructions of DNA. So what it does is this blue molecule which is there, it is reading that chromosome. Each cell makes only 4 or 5 proteins. There are trillion genes, billion genes. But we want only 4 or 5 proteins which are made, right? So only a part of that gene has to be replicated. So it's reading the DNA and then it is duplicating it. That yellow part which is coming out is actually a duplicate. And then it passes through another intake hole which actually matches it to see that it is perfect CATG, except that the T is replaced by the U. And when it's replaced by the U, it becomes a RNA. And this RNA then gives instructions to form the protein. This is happening in all your cells in your body right now as you're sitting. And when it goes wrong, there are problems and it causes aging. So how can we prevent this? So this is another sign of aging. So in the oocytes, in IVF, we all IVF specialists, we know that all of them do not become embryos. Some of them land up with missed abortions, etc. And especially aging oocytes, they have this reduced DNA damage response. And that is why we get aneuploid embryos, or they don't all become embryos, and implantation failures and missed abortions, because there is a cycle in the oocyte. The M2 oocyte first has to, when it fertilizes, first has to repair the DNA, and then it has to duplicate, and then it has to split up, because it has to split into multiple blastomeres. So that has fixed cycles. Now, if there is too much DNA damage, it cannot repair it, and you get abnormal chromosomes. And that is why in aging oocytes, in oocytes which are exposed to toxins, all these problems are seen. Telomere attrition, this is another sign of aging. Telomeres are the ends of your chromosomes. This is Eva Blackburn, who got the Nobel Prize for it. And I heard a lecture in ASRM 2019. It was a fabulous lecture. See, these ends of the chromosomes are called telomeres. And the telomere length actually, nowadays you have a test which shows you telomere length. It will tell you your longevity. It's as beautiful as that. Today, the genetic test will tell you what color you like, what is the fragrance you like. It's fabulous. I mean, genetics is a fabulous and an expanding field. So telomeres are the ones which tell you about the length of your life. And this is because of the telomerase enzyme which is there in the granulosa cells. And the thing that connects us is in blastocyst culture, because of the epigenetic changes, the environment may not be good. The telomeres are shortened and the children have shorter lives born after blastocyst. So it's very important that your lab conditions are good. So this is something, and in fact, I'm going back to the fact that maybe the less we manipulate our embryos, the less we do, is better it is. So maybe in my old age, I'm coming back to, the lesser we do, the better it is. But of course, we have artificial intelligence with the embryoscopes, etc. So you can actually pick up day 3 embryos which are good and use them. So that is something we can do. So if you look at it, all the hallmarks of aging, there's one factor which is common. See, you can do a lot of things. There are a lot of things to prevent aging or to, kind of slow down aging. There are many things which I'm going to tell you at the end. But there's one simple thing which really does work. If you look at telomere attrition, genomic instability, which I talked about, stem cell exhaustion, epigenetic, in my next, this is a series of oration which I've been giving. First I talked about ovarian aging with the oocytes. Now I've talked about all these 5 aspects. And the next one is about mitochondria and the brain. How mitochondria actually makes our hormones, estrogen and cortisol and all are made by the mitochondria. So that will be my oration in Bhubaneswar. But remember that behind all this, there's one simple thing called mitochondrial dysfunction. That actually is one of the things that can correct all these problems. Genomic instability can be, mitochondrial dysfunction is one of the causes of it. Telomere shortening, mitochondrial dysfunction can cause it. So most of the hallmarks of aging, mitochondrial dysfunction is one of the reasons. And that is something which we can really touch easily, we can help out, we can treat it. So anastasis, here comes anastasis. What is anastasis? Rising to life. How do we bring these cells back from the brink of life? They're dying and they're coming, we need to bring them back. So we have to remove that death stimulus which I talked about. So what is the death stimulus? Simple, coenzyme Q10. Not just because I've come with them, but I have read a lot of papers. I've been talking about it for 2 years. I think I'm known as the CoQ girl of India now, right now. And it's really a fantastic molecule. And multiple articles, multiple papers, I have read about it. And it's really coming out to be one of the simplest and the substance which is found all over the body. If you look at it, CoQ was discovered by Peter Mitchell in 1978. He got the Nobel Prize the year the first test tube baby was born. And it was actually found, this was a yellow substance found in the refrigerator on a hard beef which was kept overnight. And it was sent from America to Europe, from the space NASA to Europe. And there they said it was ubiquinone, and it was discovered there, and they said it was found all over the body. And first and foremost, it was said it was the powerhouse. It was in the, in the Krebs cycle, in the energy cycle, it was what was required, the coenzyme Q10. And from there, it has gone from NASA to International Space Station and now SpaceX. In fact, if you look at the different studies, ferroptosis is one of the cell death techniques like apoptosis. And if you see these 2 videos, on the left side, the cells are not cultured with coenzyme Q10, but they're exposed to a toxin, they're all dead. On the right side, the fibroblasts are actually with coenzyme Q10 and the toxin, and they're still alive. So it just shows how it prevents that death stimulus. Then this is a COM project. When astronauts fly into space, they age because of gravity and radiation. And in fact, 70% of the astronauts have retinal damage because of aging. So this was a COM project where the astronauts they were given coenzyme Q10 and the damage was prevented. So it prevents aging in of the eyes also. This was a beautiful study. I've kept it here because this is on mice. The pregnant mice were given in their last trimester a toxin. The toxin caused the litter of mice to be born with very minimal primordial follicles in their ovary. And then when that litter of mice with very less primordial follicles was given coenzyme Q10, their number of primordial follicles actually increased. So even after the damage is done, you can actually help them. I mean, that is what is so amazing about this molecule. And of course, chemotherapy, give coenzyme Q10. This molecule is being used by cardiologists for 25, I think more than that, maybe 57 years. You know, with every statin, you must use coenzyme Q10, the statins that you take. My dietitian had given me in 1992 coenzyme Q10. Now I give all my infertile patients. Of course, the ovarian aging, it acts in different ways: antioxidants, mitochondrial function enhancement, autophagy, endocrine system regulation, anti-apoptosis, and immune system regulation. And in older patients, older age group, when you have women who are 38 and above, it reduces the aneuploidy, which is seen in the oocytes. Then common practices, this is a beautiful article published in Fertility Sterility that all high-performing IVF centers use coenzyme Q10 in their women. So I would like to just end by saying holistic health means taking care of yourself, and I think it's warning your patient. You know, a girl, it's a window into future health. Reproduction is a window into future health. A young girl who comes with you with a low AMH, she may not have menopause, but aging may have started in her body. So I think a chance to take care, maybe take care of her bone health, maybe take care of her cardiovascular health. I think these are some things which we can warn our patients about. They may get earlier menopause, so we need to warn them that they're going to spend a lot of time and the quality of health is very important. So I think, I always say there are 4 pillars. You know, one is nutrition. Nutrition is very important. And today in our, you know, in the life that we lead, with so much, it's so busy. So I think if you cannot eat the healthy diet, supplements. I mean, I would recommend a multivitamin, a micronutrient, a vitamin D supplement, definitely. I take coenzyme Q10. These are some things which I think would be necessary if my diet is not good enough. Then exercise. Exercise also, by the way, creates a lot of coenzyme Q10. So, and it energizes the mitochondria. So exercise is something that should be added. The third thing is mental health. Mental health is very, very important. In fact, in telomeres, the mental health decides the telomere length of your child. So in ESAR, we've launched a program that once preconception, that you should have, like how we have Garbha Sanskar, that way preconception mental health with the Brahma Kumaris is what we've launched. And I think it's very, very important for us to pass on that to our next generation. And of course, the fourth part is the medicine. And I believe in the medicine. You know, my generation has really taken a hit by not taking HRT, menopausal hormonal therapy, because of the WHI scare. But I think it's required in the perimenopause period to the menopause. And of course, I'm doing a lot of reading. Maybe when I come next, I will be able to tell you definitely that these are the cases where you should take the MHT. You know, I think women's health is very important. We are spending more than 1/3 of our life in menopause. And it's okay to, you know, do external Botox and threads and blah, blah, blah and all those things. But what about the internal health? I think that's very, very important, and that's where we need to focus on. And believe me, if you are happy and mentally great, you feel young, you feel good, and you can really cope with all the peer pressure that's around you. Thank you. Thank you very much. You've been a wonderful audience.
Thank you, ma'am, for the wonderful lecture. Now, I would like to request all the chairpersons to please come on stage and honor Dr. Nandita.
I would also like to request Dr. Jasmine and Dr. Deepa to please join the chairpersons on stage.
Yeah, sure. Please. What are the dietary sources, nutritional sources of coal and gluten, not pharmaceuticals?
Onion, I know. Yeah, onion, I know, is a very good source.
Only onion. Onion.
No, actually, the dietary source of coincide gluten basically with the non-veg source. But it comes to vegetarian, broccoli is one thing. That is, yes, broccoli is one thing which is very good with the
Onion.
yeah, that is the thing.
That's not all.
Dr. Nandita?
Thank you.
Dr. Nandita, I would first must give you the compliment. I've seen you 15 years ago and you have stopped the aging process. And I'll just add to it, most of it was technically genetic part of it. And
Don't look at all age.
well, that's another, thank you for that. I'll just quote, Deepak Chopra, you must be knowing he's an endocrinologist, has written 93 books. And most of this center now in California talking about the aging path and, measuring the influence and other things. There he says the holistic approach, here the audience is sitting here, we are talking about the mind, body and soul. The spiritual part of this is the most important, which we are not. And he's saying that you have to live consciously, not compulsively. Most of the time we're living compulsively. When you're in that state of spiritualism where, you go into the conscious part and all of that is, this is a whole atmosphere, the cosmos is same. When you go into this kind of approach where you in the morning, as you said, the cortisol is created and it is the most damaging to the cells. And male have, 38 trillion cells and the lady, unfortunately, have 28 trillion cells. The cells are damaged. So get up in the morning, if the cortisol is there, the damaging effect of the DNA and everything will go on. But if you are exercising and doing having lots of positivity, you will be secreting dopamine, oxytocin, serotonin, and whatever it is. Thank you.
I would also like to request Dr. Bakshi to join us on stage, please.
Thank you.
Wait. Yes. He said, Digna, ma'am. Ma'am, Digna.
They look like
Nothing. I'm done. I'm finishing my presidency. I think
Now I request Dr. Nandita to please honor our chairpersons.
Hi, Darshad, please. Yes, some.
hello.
No.
Yes, सामने. सामने मैम.
I would request all of you to please stay on the stage. Mr. Raj. Dr. Kamil, please.
ले लो यार डर लग रहा है जरा
I would request all of you to please stand for Now we're going to have a quick session for the awards. I would request Dr. Nandita Madam to please stay over here. And I would request Dr. Bakshi sir, please, we are watching over here. We are not going to let you go back over there. Dr. Jasmine, please.
I would just like to request all the awardees, we like to take one photograph at the end with everybody together. So please keep your awards with you and then we'll take one picture at the end, everybody together. And at the beginning, I'd like to thank Mayor Vita Biotics who really helped me with this endeavor of giving awards, Mr. Annie and Akansha. I think thank you very, very much. Thank you. Thank you very much. And your whole team from Punjab, I think, thank you.
Yeah, now we are going to start with the Dronacharya Awards. And for the first one, we'd like to call upon Dr. Iqbal Singh Ahuja from Gujarat. I would request Dr. Kamamita Madam and Dr. Shilpa Chandra Madam to please join over here. won't be running through them. Dr. Parsi Oja here, the person from Highway Technology here. Next, I would request Dr. Sunita Parsi. I would request Dr. Amita Sharma Madam to please join for the award distribution. Request Dr. Sunita Parsi to please come for the Rotary Award.
Where is that taken?
Put in a lot of effort over the years to bring heavy technology to Punjab. I would request Dr. Mrs. Chavasam to please come over.
Yes, sir, सामने मैम. Thank you.
Our own State Chapter President, Dr. Jasmine. I would request Dr. Hazrat to please join.
Yes, सामने. Wait, inside देखना, मैम. Inside देखना, inside. मैम आपकी.
Next up, request Dr. Ashma Khanija from the National Democratic Party, CME Ludhiana, please join. The Rotary Award is about people, will be the guiding force for all of us.
Yes, सामने. मैम थोड़ा बाइक हो ना. सामने. Thank you.
Next up, call upon Dr. Monica Verma. Come over.
इस साइड देखना मैम. Wait. Thank you.
I would request Dr. Amarjit sir to please come over.
Yes, sir. Ma'am. Wait, ma'am, side. Thank you.
Next, we will be moving on to appreciation awards. I would request Dr. Ashma to please join. Dr. Ashma, madam, please join for the distribution for the appreciation awards. I will call for Dr. Bani. I would request Dr. Sujit to please join for the district prize distribution. Dr. Archana Devi has been unable to come today. I would request for Dr. Madhu Goyal to please join.
मैम देखना ऊपर थैंक यू
I would next to Dr. Neil Banot to join.
सकते हैं मैम सर आपकी बहुत हो मैम आप थैंक यू
Next is Dr. Yogeshwar Shukla. He was over here, he had to leave for an emergency. And next I would like to call upon Dr. Anupama Chopra. We have to speak forward.
सकते हैं मैम
Call upon Dr. Shweta Nanda. Please come over. These are young vibrant doctors in Jalandhar and around who will be contributing a lot.
Yes, ma'am. सकते हैं मैम
I would like to call upon Dr. Vishnu Nanda. No IVF panel will be complete without having Dr. Vishnu do a panel.
वेट करना
I'd like to call upon Dr. Prashant Patil. Come over here, Dr. Sundar.
yes what's up
Dr. Vicky Morgan. I think madam is not over here. Yes, Dr. Please take.
yes ma'am wait
Next, I would like to have the youth icon walls. I think it will be very impressive journey of Dr. Sujit. And I would like to request Dr. Sujit to come over. I think there is no center in Punjab which is not being looked after by him. And I think he deserves a big round of applause.
yes सामने
जगह ही नहीं है पीछे जाने का।
All these awards are live on Jam Plus. Next, I would like to call upon Dr. Girish Gupta from Moga.
या सामने वेट
Then we have Dr. Smriti Sharma.
सामने मैम
Next, I would like to call upon Dr. Alvinder to please come over. Besides IVF, I think any center has to have any problem with any laparoscopic surgery. This is one person who is always there to help, whether it's in Jalandhar or outside Jalandhar.
मैम आप भी आगे आ जाओ या सामने वेट
So I would like to express our gratitude to our immediate past president, immediate past chairperson of the Punjab chapter, Dr. Bakshi sir, who is already there on the stage. Dr. Bakshi sir, he's not taking any attention, so there is one token of
या सामने वेट थैंक यू
I should be the secretary. I don't deserve one, but my name was definitely put into it.
One token of gratitude for Dr. Deepak for all this help, everything.
Yes. Sir, take us, sir. Sir, take us.
I would request everybody who would like to fit into a picture, please join in over there. Space is limited, but let's see how many of you can fix it before we go on to the next panel.
Get your awards.
All those who are having the
Take picture of the model.
Maybe take it.
we can take it into fast, maybe one right now, one after the panel. Whoever would like to fit in, most welcome to join. All those who have their awards, all those who have their, they should please come over. I would request Dr. Haneem, Dr. Justine, please what's in back, come over and it's time for you to take over. As the photo session is going on, I would like to say thanks to all the doctors who have come from outside Jalandhar. They have traveled all the way and thanks a lot.
I'll take over now and you please join the photograph session.
वेट सामने वेट मैम इस कैमरे में देखना सब मेंबर मैम वेट थैंक यू
So for the last and final panel of the day on female infertility, I would like to call upon the moderators, Dr. Ritu Nanda and Dr. Jasmine Vidya, to please come on stage. I'm now going to call on the panelists, Dr. Ashima Taneja, Dr. Vinesh Gupta, Dr. Neeti Chhabra, Dr. Ranu Chhabra, Dr. Gurpreet Batra, Dr. Shweta Nanda, and Dr. Sonia Kambuj. Over to you, Dr. Jasmine.
Everyone, please settle down. Dr. Vani, would you like to join in introducing? And I'm going to request Dr.
Good evening, everybody. It's a lovely evening, and I think everyone really needs a big round of applause for being here. Jasmine, congratulations, the whole SR team, and a very, very warm welcome once again, Dr. Nandita ma'am. So, we'll start solving the riddle of RIF, the recurrent implantation failure. It's going to be very simple, and it's actually going to be a riddle solving it. So, nothing big, something to the basics. I'll just define it for you all. What is RIF? See, it would seem reasonable not to assign this diagnosis to a patient until she has failed at least 3 euploid embryo transfers or the equivalent number of unscreened embryos adjusted to her age. Because we are not doing PGTA for everyone, so we need a uniform definition. Okay, so this is how I just want each one of you to just go through the definition, because that's going to help you solve the riddle later on. So RIF describes the scenario in which the transfer of embryos presumably viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigation or intervention. So every word has a meaning. And we need to see which patients actually, by the various AI tools, have a pregnancy rate of say around 50%, 60%, but we could not achieve a pregnancy in these. These are the patients we need to evaluate. So various factors are affecting implantation: the vaginal microbiome, the endometrial microbiome, the chronic endocrine factors, the lifestyle factors, the uterine factors, the embryo factors, the environmental factors, the immunological factors, and the genotypes. We're not going to discuss it all. It's not possible to discuss all in a short time today. Now, these are three pretty women of different age groups. Mia is 26-year-old, Helen is 32 years old, and Melina is 39. Mia has been trying for 1 year, tubal factors, 3 failed IVF attempts with 3 transfers. Helen, 32 years, trying for 2 years, male factor, 3 failed ICSI, attempt with 3 transfers. Melina, 39 years, trying for less than 1 year, male factor, 3 failed ICSI attempts with 5 transfers. Okay? So each one by the AI tool has a chance for transfer. Mia has 26% chance of a pregnancy, which we could not achieve till now. Helen has 23% chance of pregnancy per transfer, we have not achieved. And Melina has around chance around 14%. Now, according to you, my esteemed panelists, which one has RIF and why?
So as per the definitions, I think the Mia, she had 3 cycles, and looking at her age must be a euploid embryo. So we can put it in the recurrent implantation failure. But whenever we talk of this, we have to look at the age. If we are looking at less than 40, we have to take it with caution that we should place her as RIF.
But all 3 have had 3 transfers by the definition.
Yeah.
So there's something else. No, we've not done PGT in any of them.
Yeah, so around 39 years, yes, she does fall into that, because otherwise 39 years, yeah.
She wants to say something.
Other than age, the failed ICSI also indicates.
To see deeply, there's something else. That's why I say it's a riddle of RIF today. The answer is there, but just 3.
What is we saying the attempts with 3?
But we know, I think the answer is Mia, but why?
The attempts with male factor. Male factor.
Absolutely. There is no male factor in Mia. She only has a tubal factor. Okay? There is no as such. In others, we factor which is leading to a failure, could be leading to a failure, We know there is some problem in the male. In this one, we don't have a problem as such. Tubal factor is not a reason to be, leading to an implantation failure. So we need to evaluate Mia why we have not reached. Why? Now please just see these parameters clear, absolutely, very soundly, because the answers are here. The riddle has to be solved from here. Okay? So Mia is 36 years. She has a BMI of 23. See, I'll tell you, the right BMI is 20 to 25. Yeah, it is 20 to 20. Even less than 20 is not good. More than 25 is not good. So she has a cycle of 30 to 34 days, occasional spotting. So she's not attained any pregnancies till now. Both are non-smokers, the Mark and Anna. Do not take regular medication or have a chronic illness. Family medication is negative for any reproductive disorders. Mark is 34, me 24, normal sperm test. Okay, so she was stimulated with 225 units of menopause in the first cycle. We got 7 oocytes, IVF, 2 PN, and 1 blast, 5 AB. Then second stimulation, 6 oocytes, 4 2PN, 1 blast, 3 AA. And endometrial thickness, if you see, both cycles good enough. First cycle ET was done and a failure. Second again, first cycle ET was done with the blast, again a failure. Third stimulation with Pergoveris, 300 units, 7 oocytes, IVF, 6 2PN, 3 blast, 5 AA. First cycle with 11 millimeters of endometrial thickness, 5 AB and 4 AB were vitrified. Okay, we did a transfer, 5 AA and the rest 2 vitrified. Again a failure. So 3 failures, she comes in the RI. Now you tell me what next. How do you go about to evaluate her and do what? what you think should be, ma'am, I have a crash man. I want all of them to talk. So one by one, everybody.
We do not know her progesterone levels in any of the cycles, so we can consider doing the progesterone
No,
levels.
just don't jump to the investigations. I want that when we have a RIF, okay, by the guidelines we have now, we should reevaluate. Start from the history. Anything in the history we think. No, she's not 36. She's just 26. She's not 36. Oh, yeah, sorry. She's 36. You are right. She's 36. Yeah, occasional spotting, one thing. What else you want to evaluate in her?
Lifestyle factors.
What lifestyle factors?
Lifestyle factors like smoking. They say she's a non-smoker.
They're non-smokers.
Any high levels of stress.
Yeah, very good. Very good.
She's not obese also. So I think stress, smoking and obesity are the three factors that we assess. So in her stress levels.
Anything else, Shweta, you want to add?
Uterine factor has not been mentioned. She needs to have some kind of basic uterine evaluation in addition to the other usual blood tests.
What kind of uterine evaluation do you want to do?
Any basic SSG or HSG would be good enough.
No, we don't need SSG, HSG because she's for IVF.
Yeah.
She has blocked tubes.
Then
She has blocked tubes.
and she has got spotting also, so we can do a hysteroscopy prior to that. And do an endometrial biopsy and both the chronic endometritis.
Yeah. You mentioned endometrial biopsy. What do you want to see in that biopsy?
Any endometritis or any infection.
What will you ask the pathology lab to check when you send that biopsy?
Basically, tuberculosis is out, and apart from that, yes, you can take cultures also, and the pathologist has to look for, in case we are looking at a chronic endometritis, the pathologist has to look for the plasma cells.
Absolutely, absolutely. I want, like you all mentioned, something beautifully you guys picked up, that she has occasional spotting. So what does occasional spotting signify? Definitely think of endometritis. Occasional spotting points towards endometritis. So both have a normal lifestyle. Endometrial thickness seemed fine in all 3 cycles we have seen. Vitamin D was normal. You must check the vitamin D levels as well. Okay, and she was negative for APLS, TSH was still normal, all cycles fresh with progesterone circulation. This is what was done, I'm telling you. Yes, what all you need to, somebody mentioned lifestyle, correct. We need to reassess her endometrial thickness, okay? Don't go by what others say. We need to see just not the thickness, the vascularity of the endometrium as well. That is very important. And if this patient has chronic endometritis, there could be a lot of changes in her endometrial vascularity, which is going to affect our implantation. So assessment. You can ask for karyotyping, you can ask for, 3D ultrasound and hysteroscopy, endometrial, chronic endometritis you all have talked about, and very beautifully, Dr. Mashima said that yes, we should look for plasma cells and the CD counts. So the labs they give you. So when you send a biopsy, you should ask, in a case of chronic endometritis, we should ask for plasma cells, the CD count. Now, as you all said, as Shweta said, hysteroscopy. What did hysteroscopy show in this patient? There was hyperemia and micropolyps. So they both signify chronic endometritis. She also, that's the history which made us think of hysteroscopy, right? So the CD count was around 21 cells. So what is the first line therapy you all use for this patient?
Doxycycline.
Doxycycline for how long?
Actually, it should be given for 1 month, but yes, we give only for 14 days or maybe 21.
No, but a lot of evidence says 14 days is enough. They don't say to, give for 1 month for everybody, because if we practice evidence-based medicine, then we need to recheck and reevaluate the plasma cells. Now, can somebody tell me a non-invasive way of reevaluating? We can't go and do the biopsy again and again. We can't do biopsy twice in a month, We did it once and now again after the course. Can anybody tell me a method of reevaluation without a biopsy? Absolutely. You take the mic and say, no?
First day menstrual blood sample.
Absolutely, perfectly. And there are a lot of papers, I think in between I'll get on to it. I'll show you there are a lot of papers which say the non-invasive method, the first day best. And how it has to be collected, that is very important. How it has to be collected. How will you ask the patient, how will you collect it? That is very important. You have to ask the patient, you have to give them a menstrual cup. She has to use a menstrual cup, and from there you're going to send the sample. Okay, that's how we have to take it.
I would like to add
Yes.
probiotic to doxycycline as well. Because I think use of probiotics has helped us a lot in cases with chronic endometritis to improve the microbiome in the endometrium.
See, the probiotics now, if you go through many papers, they're not.
But I would still add, and I would like to ask everybody here who's practicing, because see, even if she was not for IVF, when we are treating recurrent vaginitis or chronic PIDs, aren't we all giving probiotics now? And this is practically we see, because see, if we look at literature again, Indian literature is not something that is reflected.
I agree with you, Vani, but one thing I would disagree also, because I think the vaginal microbiome and the endometrial microbiome, which has been studied again from the European world, I am sure it doesn't hold good for our women. It is not let's say if we take the cultures from the vagina of this Asian Indian woman, it is going to be very different from them. Very different.
Lactobacilli agalacticus predominates the flora of the vagina, which regulates its pH. So if the pH is not maintained, that is the primary reason for the other bacteria or the other infecting organisms to grow.
Absolutely.
So then probiotics hold a role, if not directly influencing the flora, but in maintaining the pH.
Dr. Ashima, in your institute, what do you practice?
No, we do not give
Even I don't.
probiotics. Yeah, we are waiting for the robust data to come in, and so that we can.
Because a lot of evidence doesn't support it now. There was a time, a couple of years ago, we all used it left and right. Okay. So which is a second line drug you would like to use? Anyone differs in the first line drug? Because there is evidence for another drug as well.
I can give ciproflox, oflox.
That's the second line drug. The first line, clindamycin, anybody is using it? There's a lot of evidence on clindamycin, 300 milligram. It works wonderfully, and we do not find much resistance in it as well, because in doxy many times you will find resistance and not responding to treatment even. So ciprofloxacin is a second line of drug, again for 14 days, added with metronidazole. Okay. That's a very, very, what do you say, a pat on the back for all of you. So when you cured chronic endometritis, as you all did, so how did you increase her live birth rate? By around 32% from 22%. So 10%, a very, very significant, improvement. So very well done. So this is the histology picture I want you to see. The 21 CD counts, the 21 cells. After 14-day doxy, it came to 17 CD cells. And then after the second line, it came down to 9. Still, it did not zero down. So the third line was given in this particular case. Azithromycin was given 500 milligrams for 3 days, and then it came down to 1 CD cell. Okay. Suppose a patient doesn't respond to antibiotics. What next can you think in her? It's very no rocket science. Scratch your heads and you all must know it. You all do it as well. Huh? No. If antibiotics are not responding, what else can be there? Oh, exactly. Antifungal. So if antibiotics are not responding, she's not responding to antibiotics, give antifungal, and antifungal for at least 14 days. So the two embryos were vitrified. So one of them was transferred, and here is the, you all achieved her pregnancy. So a big round of applause for our panel. They went in the right direction. So why we want to talk about RIF? Why we all want to just talk about it? Because 70 to 80% of the transferred embryos do not give birth. And that is a huge number. And I just wonder that much of wastage goes, how much effort goes, how much manpower, money goes in the making of these embryos, and they just go down the drain. And I think collectively we all can improve one day in our practice, and maybe that much of wastage may not happen. I think it will not happen that even we talk of RIF at 3 cycles. I think we all, in our busy practice, maybe need to spend another 20 minutes extra on every couple, reevaluate them. I think somebody would have worked on this patient, on chronic endometritis prior to her 3 embryo transfers. This wouldn't have happened. So actually, it is negligence. If we really see, when we are evaluating, we should not miss chronic endometritis at the first goal itself, right? So somewhere the deficiency is within us. So case 2, 38, I think the most beautiful part, when we discuss cases like this, I think we all need strength to come up and discuss, because we discuss our own deficiencies, and when we discuss, definitely we improve. And definitely certain things when we talk and discuss, they leave a mark in our grey matter, and maybe next time when we are seeing a patient, we would remember that, right? Simple things, very simple things, and unfortunately very simple things get, missed. So this is a case, she's a 38-year-old young patient. Her medical history, she had come with dysmenorrhea, ultrasound sign of adenomyosis, no male factor. Her ART history is, in 2017, she took 6 cycles of clomiphene. In 2018, 1 IUI cycle. In 2022, 3 implantation failures. So these 3 implantation failures, just I'll give you a little detail of that. Her stimulation was done with pergoveris, 12 oocytes were achieved, 2 PN, 5 embryos for which PGTA was done, and 0 euploid embryo. This patient had come from abroad. This is what she came with. So stimulation with another cycle, they did stimulation with pergoveris. So they had 5 2PN embryos. 4 embryos were taken for PGTA, 2 euploid embryos, and they did 2 frozen embryo transfers, and again a failure. Okay, so this is the details which she came to us with. So how do we proceed from here?
Positive history is that dysmenorrhea, adenomyosis, and we have to look at the endometrium.
Positive history is dysmenorrhia,
adenomyosis, and we have to look at the endometrium, whether the endometrium is receptive in this case, because otherwise,
also adenomyosis per se. We have some more mics here. Hello? Do we have some more mics here? Can we shift the mics? I think one. Sonia, you have to start saying something. I won't let you go silently. I've seen you after a long time.
Basically, any patient who comes to us with adenomyosis, we need to reevaluate first that how is the endometrium, how is the endometrial lining, and where is the basically uterine mass, is anteriorly or posteriorly, or it is a globular uterus. So then accordingly we evaluate the patient, and maybe we need to treat her first for adenomyosis and then do a frozen cycle later on once we have.
No, we will first go to evaluation. We won't go to treatment first. What more? You said you need to check the masses. You also want to see how close it is to the endometrium, or how far it is from the endometrium. Can you tell me how does it matter?
It matters in the sense because if we are implanting embryos in such a patient, the implantation rate goes significantly down if the myometrial glands are present in such patients. And if the muscle mass of the uterus is more on a particular place, we have always seen that the implantation rate and the live birth rate goes significantly down. So we need to evaluate this patient what best we can do for her. If the muscle mass of the uterus is more in a particular...
No, I want you to tell specifically how does the distance of the adenomyoma to the endometrium matter? Does it matter or does it not?
It matters.
No, turn by turn now. This half has the mic. I want, Ranu, anything on your mind?
Sometimes there are inflammatory reactions too, which we can see in the patients.
No. I'm not asking all that details. I'm just asking, does it matter the distance between, see, this is the endometrium, and this is your mass. If suppose it is 2 centimeters away from the endometrium, or it is just close to the endometrium, does it matter? Does it matters? Anything else, Ranu, you want now? Adenomyosis is over. Anything else?
Yeah, definitely, because this type of adenomyosis is going to create some problems with our endometrium, and it can lead to implantation failure also, because of the inflammatory cytokines which are released due to adenomyosis, and that can be a reason for implantation failure. So initially we have to take care of the adenomyosis, and also I have seen like it may be associated with some ovarian endometriosis, because we have seen in endometriotic patients the sites are not, we don't get good quality of sites, so that could be the reason of
Absolutely, very good point. See, I mentioned adenomyosis. That also, we should just forget what the other person has done and seen. We should evaluate it as a fresh patient. We should not just, think of adenomyosis. Once adenomyosis is there, look for endometriosis in the ovary. Absolutely perfect. Because many a times tiny endometriomas are missed. They're not even, mentioned in any of the reports. And when you see, or maybe as this patient has been, one treatment in 2017, 18, and now 22, and now 23, she comes to us. So we need to, recheck. Things will change. They won't remain the same also over the years, So anything...
But the fact that she had 2 euploid embryos tells us that we have at least overcome some, because in her first cycle she didn't have any euploid embryo. But we managed to get 2 euploid embryos. But implanting them in a bad uterus, we lose the game.
Absolutely.
The idea is to first, like somebody mentioned, treat the adenomyosis first. Or these are the ideal patients.
No, I want, Bunny, that anything else we need to look about, we're talking about the uterus only. Now let's get out of the uterus and think of something else, Let's not just get caught in the box. Let's think out of the box. Anything else we need to check? Nikki, you want to say anything?
Apart from the endometriosis and the adenomyosis, we can look for extra pelvic adenomyosis, which could be the cause of a dysmenorrhea, something which might not be visible on imaging.
So something which will help in our RIF, the management of this patient.
They might have some hydrosalpinges or something along with.
We need to look for things now. See, when we reevaluate, this is how we should go about. Okay? Take the history again. Take the medical history. Do the physical examination. Do a pelvic 2D ultrasound by itself. Check things. Don't go by what you have in your hand, the reports. See, assess the ovulatory function. Do your AMH or the ovarian reserve. And the same.
Frankly, this is the checklist you do before you take up the patient for, she's at, this is her 3rd pickup, right?
No, but this is not what she's come with from, from another center. Now she's come to you. That's what I said. That's what I said. She has come, she came from abroad. She came with that history, all those, PGTAs and everything, and still no implantation. Okay? And then we need to reevaluate, because if we do not reevaluate, we're going to miss something. If we just go by what they have done, we miss. Absolutely. And I tell you, the Indian doctors are much better than these European doctors. I'm sure nobody from Europe is here. No, because we think very logically, they go by the guidelines. है ना? वो क्या कहते हैं? लकीर फकीर क्या बोल? What is that? लकीर के फकीर, that like that. See, we have been individualizing our treatment ever since I think we know IVF, right? They're talking about individualization now. Earlier they always framed the guidelines. this particular patient, this much what you do. We never did that even in the earlier days. We always thought every patient is different. So this is how we should go. This is how we should go. Also, think of small things. BMI, nutrition, the vitamin D is very, very important. Make sure the vitamin D is enough. If it's not, please supplement. Any physical activity, it will help in getting a good egg. And what are the pap smear? Because many times we jump to IVF and there's a bad cervical lesion sitting there. I don't know how people missed it before you, but still it's there. We need to treat that. So no drugs, no alcohol. We know that all. So what did we do? As you all said, we did an ultrasound. There was an adenomyosis. There was also a thickened endometrium with minimal fluid in the cavity. Okay, hysteroscopy. This is the last case. I had only put 2 cases. So this is what we did. When we did an ultrasound, we found a thickened endometrium with minimal fluid in the cavity, hysteroscopy, as you all would do, and an endometrial biopsy, which showed again, and the EB also showed increased uterine NK cells and increased IL-18 cells. Her TSH was 4, her AMH was 0.8. Would you like to do something for this TSH? This is what we evaluated. She came with a normal report, but when we did, the TSH was 4. So would you do something for this TSH?
Normally we do TPO antibodies also, and if it's positive, I would like to treat.
Otherwise?
If it's negative, I would definitely reevaluate her TSH, because ideally we like to maintain it between 2.5 to 3.5.
Yes.
So, I mean, this is a borderline high for fertility. So a lot of practitioners do give low dose of thyroid.
For this patient, we evaluated it. Again, it was around 4.5, but the TPO was normal, okay? But we started her on 25 microgram of, so this is some slide which got missed and displaced. This was that slide, that menstrual blood, how it can be taken. Now, I'll tell you what I did. Now you have another picture. Forget this slide here. Now, what would you like to do? Each one will tell their protocol for this patient.
For this patient, definitely she is for long protocol, because she needs downregulation to cure her adenomyosis. Her AMH is 0.8, so the stimulation has to be again a combination, and I would go up to even maybe 450 IU. And treat, they should, ideally before taking up for another pickup, I would like to see the uterus first, because there is inflammation related to adenomyosis. Maybe 2 injections for a GnRH agonist followed by stimulation, and then take her up for IVF.
Very good. Anything?
I'll differ in
yes.
I'll do an antagonist protocol with a good dose, 450 is good. I'll freeze the embryos, then I'll down-regulate.
Suppose you get only 1 embryo, what will?
One is
even then you're going to freeze it?
Yeah, because she's got fluid, she's got adenomyosis. So rather than giving the GnRH first, and that will further decrease the cycle. So I'll freeze the embryo and then give maybe 2 to 3 injections of lutein.
I just want to give, there is a lot of evidence now in support of these patients with adenomyosis or endometriosis. We are going back to the long protocol because it gives us better and more chances of having euploid embryos as compared to antagonist.
I agree with you, Vani, but I feel in compared to agonist and antagonist, I think it is each one's comfort. Even what she said, like if she could go to down, take out the egg and freeze and then down-regulate the 2 cycles. Even we have a lot of evidence, which supports, because adenomyosis, you would need at least 2 to 3 cycles to, get a better endometrium. Anybody wants to?
Her,
Yeah,
her AMH is already very low.
0.8. This is what we did. This is what we did.
Going for the long protocol would be like reducing her size further.
No.
Sometimes it does.
No.
Sometimes it does.
No, it won't, because there's a lot of evidence. See, it is each one's comfort. I know Vani loves the long protocol. I don't use it. I only use it once in a while that I don't forget it, okay? So I don't forget how to do it. So otherwise, even I would do what
We are practically doing antagonists now, but for endometriosis and adenomyosis, we are still thinking, and even in sometimes in poor responders, we have seen going back to long protocols has given us better results.
Okay,
now we have evidence. Now we can also add letrozole for embryo. I mean, we can downregulate after the stimulation, either with an tag or with the agonist for transfer. Before the transfer, along with the GnRH agonist depot, we can also add letrozole.
Yeah, you can add.
And then once the levels of E2 are really low, the cutoff that we take in them is less than 20. So then we would transfer, and embryo pooling if the number of eggs is less.
Now see what we did. Down regulation, we did down regulation with Euprolide 3.75 for 3 cycles. Vitamin D supplementation, I gave thyroxine 25 microgram. I stimulated her with Menopur 300 international units. 3 2 PN embryos we got, and only 1 blast. No PGTA. I did not do any PGTA for this 1 blast. So ET done with 1 blast. I added prednisolone 5 milligram. Progesterone per vaginum I gave Prenogel BD. Injection progesterone 100 milligram daily we added. There's a lot of evidence now to use 2 routes of progesterone. Okay, if you're using oral, add another one as well, because the oral and the injectable have a different serum levels. But the vaginal is basically will not give you a serum level of progesterone. It will only give you the uterine, the best effect there. See, this is the difference what we get when we downregulate. This is before when you downregulate, and this is after when you downregulate. That is the difference you get in the endometriomes. There's a marked difference. That is why downregulation is very, very important. Now, I have something very, very important which I wanted to discuss here. We did, because there were so many failures, just adenomyosis is not one thing. There was endometritis, we treated her endometritis. But another thing which we checked was her natural killer cells, NK cells. We can check, the labs are doing it here. So when they are raised and when they are low, the modality of treatment is different, okay? And now can somebody tell me anything about these immune regulation? It is very, very important, the immune regulation, because हम लोग पहले क्या करते थे हर किसी को, I'll tell you why I do not add a corticosteroid just like that. I rarely use a corticosteroid because it is a double-edged sword. If corticosteroids in 50%, they will give you an improvement in your immune profile. In 30% of those patients, they will worsen it. So we have to be very careful when we use it. So can anybody tell me how in this patient, I'm telling you I gave her prednisolone. Can somebody tell me what could have been my reason to give you? I also brought out that the killer NK cells were increased and IL cells were also increased. I've given you 2 clues and why I used it.
Ma'am, these are both inflammatory mediators and they have an immunological role. So considering steroid was a good option, also immunoglobulins can also be considered in such a patient.
Immunoglobulins, you want to add immunoglobulins?
But
there is no evidence for immunoglobulins. There is no evidence. I think we should not just use the drugs without the evidence today. We should not. Because whatever given is a chemical combination, it is getting into, as Ma'am beautifully talked about the genome and the epigenetics. Don't forget that every drug is going to have some impact in your germ cells as well. So I don't think in today we should just give anything just like that. Immunoglobulins, no evidence is there, and I don't think they should be used. Till we get evidence, yes, that it's going to help. वो क्या होता है, किसी एक में आपने लगाया उसको बेनिफिट हो गया है ना, किसी एक में लगाया नहीं हुआ, because we do not have a concrete reason. But you know, now what is immune profile? Anybody is going to tell me, or should I sum it up fast? So see, this is something very important. The immune profile may help women with repeated unexplained embryo implantation failures. So we must identify what is the immune mechanism. So there is two types of immune reactions in a lady, in a proliferative phase and the secretory phase. In the proliferative phase, you have the adaptive immune system, and in the secretory phase, you have the innate immune system. And that balance, that switchover which takes place in the mid-luteal phase is the time of window of implantation, where we talk about pinopodes and so much of reactions taking place. There is a balance which is drawn. So any excess of any of these or an imbalance in these, we need them all. We need all of them. But the imbalance, either it will lead to no adhesion or no apoptosis of these blasts what we have or the embryos we have. And when we don't have apoptosis, so forget the invasion in the endometrium. So the implantation failure. So there are two types of profiles. Now it is something very interesting. The low local immune activation and the high. These are the last two slides, but I want all of you to just remember them because it's so beautifully put. See, there was a time, I hope you all will agree, there was a time we were all doing scratching for everybody. Were we doing or not? A new vascularization for everybody, is going to help. Now, how beautifully it has been unveiled, why it won't help. If your profile, you need to check your immune profile of a patient, which can be checked in the menstrual blood, but the best time is the 21st day, the mid-luteal phase of an EB. Okay, so profile of a low immune, what you need to do, what are the strategies which will lead to the activation of immune cells when your profile is low? Endometrial scratching, is that what can you do? Then you need to go for what we talk about, low dose stimulations, not very high dose stimulations, because if you have a very high peaks of estrogen, that is going to further suppress your immune reactions. Okay, then third, supplementation of mid-luteal, low dose of SCG. Again, it will activate the immune reaction. And a sexual intercourse after embryo transfer. There were beautiful papers in 2008 about these, sexual intercourse after embryo transfer. There's one very nice Egyptian paper I had gone through long ago, but many a times your patients don't comply with this. After an embryo transfer, bed se nahi utna chahte, and you tell them to have sexual intercourse, they don't listen to you. But there have been papers which say they have a positive effect of the seminal plasma on the recruitment and activation of the TREG and the uterine NK cells. Now what happens? Now I had high uterine NK cells in that patient. So their immune reaction activation is already on the higher side. So what did, no local injury, no scratching for this patient, standard ovarian stimulation, or even you can do a frozen embryo transfer where you're adding your estrogens. That means standard means you can use your, as one is a high dose of your stimulation, where even the estrogen rises high, good for you, because you want to bring down the local immune reaction. So, and adjuvant therapy like high dose of progesterone again will lead to immunosuppressive properties. And you can also add antioxidant like vitamin A. It helps. And prednisolone, a corticosteroid, the dose maximum you can give is 20 milligram per day, but I only added 5 milligram because we were doing other added factors also. The estrogen was also high. So, in case of resistance, slow perfusion of intralipids, but I do not do, I did earlier, but I don't prefer intralipids. No sexual intercourse specifically to be advised to this patient. So, this was the reason we added the prednisolone, and I gave high dose of progesterone. Yes, Dr. Ashima?
Intrauterine transfusion of PRPs can be considered.
But there is no evidence as of now. I do it to increase the endometrium, but not to improve the immune profile.
Yeah, it will. Yes, you're right. We do not have the sufficient evidence.
No.
That's great.
But Dr. Ashima, she already has 9 mm, 10 mm of endometrium. So we don't need a PR infusion in her, right? So this was the case, and
Just a question.
yes.
Dydrogesterone, but we know that it has immunomodulatory properties because you yourself said that NK cell, there was a...
So no, I added progesterone. No, I don't.
No, because specifically we know now that dydrogesterone has...
I tell you, Vani, of late, dydrogesterone has been causing lot of derangement in the liver enzymes. Lot of liver, अभी मेरा एक patient था पीछे. I had referred her to DMC Ludhiana. She almost had findings of acute fatty liver of pregnancy. We had to just shut down. I was just giving her one OD dose, Even that we had stopped, and she had skyrocketing, SGPT levels, SGOT levels, which your team there, brought it down to progesterone only. And this is not one single patient, but if you see the oral progesterone, it's only a lot of it goes into the the liver bypass. The maximum effect which you get is the intramuscular and the vaginal route, and you when you give vaginally, it gives you the immunomodulatory effect equally, the immune suppressive effect even better than your oral. And please.
Do you have any experience about the continuous dose of letrozole? Because given
continuous dose of
letrozole.
Letrozole. In adenomyosis?
Yes.
For how long?
90 days.
90 days?
Yes.
I have prior to
before transfer. And I have literally seen that the myometrial mass has been reduced and the patient conceived after that cycle. Of 90 days we have given letrozole and then we start with all estrogen and progesterone.
Did you check her estrogen level?
Yes, ma'am.
What was the level after 90 days?
After 90 days it was just 15.
15?
Yes.
See, 15 is this is what letrozole does, which estrogen which is required.
But even when you give this with the estrogen, we did, we gave 90 days of letrozole, then we started with this estrogen gel. We gave it for 10 days, the endometrium was just 7.5. It was a very nicely dry line, and we transferred very good embryos, and she is pregnant.
See, anything which will reduce the mass, basically it stops the end.
It was reduced, very much reduced after the use of letrozole.
See, we can only say that it got reduced because you saw in that particular patient.
No, ma'am, I am actually doing a PhD and my topic is different implantation failure. So I had a lot of papers about that. Then we started that, and that we really saw the results in few patients.
Because I personally prefer Danogenes, okay, because it does not bring the estrogen down to bring you any side effects of your down regulation.
Just see that. Thank you.
See, they all want me to. They're going to stop the mic for me now.
Central and elaborate discussion on treatment implantation failure. Now I invite all my chairpersons on the dais to facilitate Dr. Nanda and Dr. Jasmine. And Dr. Chawla has some questions from I think we can take them during dinner.
I like the first one.
Please join us.
Letrozole is far better than Lucrative. Lucrative only stress the estrogen is open. Letrozole stress estrogen every organ, every part. So it is far better than
Thank you, doctor. I have no experience on letrozole, but I definitely go and read more about letrozole. And then we're going to discuss on the next airport at Amsterdam when we meet.
Come to my center, it is on the line of airport. The schedule with letrozole is more than 1 decade.
Thank you. Thank you so much, Doctor, for sharing your experience.
In the meantime, let's have a photograph over here.
Yes, ma'am. सामने. मैम इस साइड देखना सब मैम. Thank you.
I would request Dr. Nandita to please stay on the stage. Dr. Jasmine to please stay on the stage.
Dr. Justine, Dr. Numa, please come over. Is Dr. Sajjit around or is moved out? A token of appreciation from I'd like to have Dr. Justine over here, please.
मैम देखना.
And Dr. Hadid over here.
Yes, सामने. मैम. Thank you.
Thanks, Dr. Hadid, Dr. Justine, Dr. Anupama Chopra, Dr. Sarjeet Singh, Dr. Anupama, please stay back. I would like to thank Punjab Plus Managing Director, Mr. Rishi Garg, for having spared his time and giving a live coverage for the entire program. I would like to thank Mr. Raj, Mr. Kapil, Ms. Manna from Embryo IVF Chabla Nursing Home. From the bio team, Mr. Ani, Kanksha, Jitinder, Manjeet, Puneet, Satish, thanks a lot for organizing the entire program. I would like to thank Shama Rani and Raj from Nova IVI for helping us through at the registration desk, and Mr. Gaurav and team at the audiovisual, our photographers over here. I don't know the name of everyone. Mr. Ashok is over here and his team. I thank you all for helping us through the entire program. And I should be forgetting to thank one person who has been behind us, pushing all of us. Dr. Navjot Dahiya, he's sitting behind and he has been actively pursuing. Thank you for helping us at the back end. Thanks a lot. And thank you, Dr. Nandita, for having come over here to Jalandhar for all the way. I know you cannot travel at night to Chandigarh. I think it's safer to travel in the morning. I think a lot of people have left, but there was one who wanted to have some small dance before the end. I think it will be back to Dr. Jasmine, so to call everyone and please have a session.
I would request all those interested in dance to please join us.
Not interested, doctor. dinner is ready. The dinner is ready. I think everybody is tired. I think it's time to wind up. Thank you, everyone. Please enjoy the dinner. Thanks to each one. I think there's someone really interested. Someone interested. Dr. Rajeshwari, Dr. Kumar, Dr. Sandeep.
सज्जणा नु इन्ना ना सताया करो दी कदी साडी गली भुल गई आया करो दी कदी साडी गली भुल गई
Hello, hello, तू फ्लोर पे नजर आई येलो येलो बड़ी सॉलिड मस्ती छाई हेलो हेलो तू मुझे दिल लगाई येलो येलो कंट्रोल करो मेरे भाई चेहरा तेरा गुलाबी कोई ना युगला जा जो इतनी को बैठा हेलो हेलो दिल दिल से कनेक्ट करना येलो येलो ये बातें डायरेक्ट करना
पूरी ने रुकियां ना भी टप्पे 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 पहला का पूरी ने रुकियां ना भी टप्पे पीछे भी ना करो यार पैर भी नहीं रखे चलो कि मैडम जिसके घर में आई बस पार्टी दिया गल्ला कर दी रंगी ये पूरी सैंडल 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 कर दी रंगी तेरा रंग बल्ले बल्ले, तेरी चाल बल्ले बल्ले, तेरा रूप बल्ले बल्ले, तेरी ढाल बल्ले बल्ले, तेरा तुझे तो मुझे प्यार हो गया, तेरे ख्याल में ये दिल हो गया।
ओके इसमें जो है और आपने भी पूरा जो है एक ऐसे टॉपिक को छुआ, क्या कहना चाहेंगे कि ऐसे सेमिनार जैसे CME जो निरंतर ऑर्गेनाइज की है ऐसी होनी चाहिए।
महत्वपूर्ण है कि जो जिन्होंने लाइफ उनकी डेडिकेट की है 10, 15, 20 साल IVF को दिए उन्हें हमने आज फेलिसिटेट किया है और उन्हें अप्रिशिएट किए हैं। और ये जो सेमिनार आज का था वो बहुत ही डिफिकल्ट सब्जेक्ट्स पे था। एक तो एजिंग पे था, फिर मेल इनफर्टिलिटी और IVF फेलियर्स पे था। जो एजिंग है वो तो बहुत ही डिफिकल्ट सब्जेक्ट है क्योंकि और बहुत इंटरेस्टिंग भी है क्योंकि काफ़ी हमारे IVF लाइन में हमें यंग लड़कियां मिलती है जिनके ओवरीज बहुत ही मतलब उनकी उम्र होती है 28 साल और ओवरी की उम्र होती है 40 साल। तो इसलिए हम कोशिश करते हैं कि उन्हें हम मदद कर सकें और काफ़ी कुछ आजकल की जो लाइफ स्टाइल है, जो एनवायरनमेंट है, उसका भी असर होता है हमारी फर्टिलिटी पे। तो जब कोई भी पेशेंट IVF के लिए आता है तो उन्हें मैं 3 चीज़ें ज़रूर बताती हूँ कि आपका पोषण जो होता है वो बहुत ही इट शुड बी ऑल राउंडेड। फिर दूसरी चीज़ है एक्सरसाइज की, वॉक करना चाहिए या योगा करना चाहिए। और मेंटल हेल्थ मतलब दिमागी हेल्थ जो है, शायद आप मेडिटेशन करो या हैप्पीनेस या पॉजिटिव एनर्जी फील करना बहुत ज़रूरी होता है। अगर आपकी लाइफ में कोई स्ट्रेस है तो ये स्ट्रेस से कैसे डील करना चाहिए ये बहुत ही इम्पॉर्टेंट है। और चौथा बात है मेडिसिन तो आपके डॉक्टर आप उनको ट्रीट करेंगे और उसमें तो बहुत सारे मदद कर सकते हैं। और IVF ओके थैंक